It's time to start now. It is my pleasure today to introduce a topic which is very dear to the patients, the GI involvement. There are not at the moment many studies around this topic, even if the situation is changing and some studies have been started. There are some ad hoc committees that study on this. What we are waiting for is the pharmaceutical companies to hear our unmet needs and start developing something for our GI. We have the pleasure to have here today with us Catarina Leite, you all know her, a patient advocate from Portugal, Professor Yannick Allanore from France, and Professor Zsuzsanna McMahan from the United States. Catarina is a Portuguese health psychologist, and she's specialized in the field of health psychology with a specific focus on chronic diseases and patient support. She's the founder and president of the Associação Portuguesa de Doentes com Esclerodermia and an active member of FESCA. She lives with her husband and her beautiful son, 10 years old. She enjoys traveling, spending quality time with her family, and above all, helping others, a value that guides both her personal and professional life. Professor Allanore is professor of rheumatology at Université Paris-Cité since 2008 and is working on rheumatology in the rheumatology department in Paris at Cochin Hôpital. He's leading a research team working on the cardiopulmonary aspects of systemic sclerosis through clinical research programs and basic research ones. He is deputy director of Cochin Institute and has published over 580 articles in peer-reviewed journals. He is a member of several professional bodies, including the French Rheumatology Society and American College of Rheumatology. And between 2013 and 2019, he's been elected chairman of EUSTAR, the branch of EULAR that is focused on systemic sclerosis. And he's now a member of the board of directors of the World Scleroderma Foundation. Professor McMahan, she is the professor of medicine in the division of rheumatology at the University of Texas Health Science Center in Houston, where she also serves as co-director of the Scleroderma Center. She has an extensive expertise in systemic sclerosis. Her research and clinical work focuses on gastrointestinal involvement in scleroderma, disease mechanisms, and patient-centered outcomes. She has authored over 100 peer-reviewed publications, and she's an active leader within the ACR, which is the American College of Rheumatology, WSF, the World Scleroderma Foundation, and the Scleroderma Clinical Trial Consortium. She serves also on the board of directors of the Rheumatology Research Foundation, and she's widely recognized for her contribution to advancing the understanding and management of scleroderma-related gastrointestinal disease. In this session, we should not name any kind of medicine due to pharmacovigilance, and either by speakers and by the audience, please. So let's start the session with a question for Catarina. And let's try to understand the burden of the disease. You have already spoken about this. What is the impact of GI involvement in daily life, Catarina?
I think, good morning. I think for many of patients, me included, the gastrointestinal involvement is one of the most exhausting and invisible part of the disease. Is not only discomfort, swallowing is difficult, sleeping, sitting up because of the reflux, and being constantly worried about bloating, pain, or needing the bathroom urgent. That can affect our energy, our social life, our confidence, and even our relationship with our own body. Many patients feel isolated because of these symptoms are hard to talk about.
Thank you, Catarina. Yes, it's very difficult. I know you and Ada said that when we enter a room, we have to check first where the toilet is, because you never know when you are in need of it, and you have to really run to the toilet without stopping what you were doing, yeah, right?
It's very difficult. I made a reservation to the restaurants and asked, please, a table next to the bathroom. That is the table nobody wants, but it's a preoccupation to many of us, I think.
And thank you for talking about this, because it remains a taboo. And I can understand if you feel shy to raise your hand and ask a question. So please use a Slido. I ask, please, if you can put the slide with the Slido QR code. And do not hesitate. I encourage you to make questions. So already 2 have arrived. So very well, we will answer after our speakers finish. So, Zsuzsanna, what is the importance of the collaboration within rheumatologists, gastroenterologists, and pulmonologists, mainly for the reflux?
Well, thank you, Ilaria. First of all, it's really nice to be here with you today. Scleroderma GI disease is something I'm really passionate about, and I see your struggles and really admire each of you for facing them with such grace and bravery, because I don't know how well I would live with them, and we're doing our best to really make a difference in your life, and that's one of our goals in our career. But to your question, Ilaria, the multidisciplinary team is really important in optimizing your care and outcomes, because when doctors of different specialties work together, they each have different perspectives and can really come together to create an optimal plan for your treatment. So the importance of rheumatologists in that team is obvious, but the gastroenterologists really can complement the rheumatologists in terms of their ability to perform various procedures, obtain tissue, and sometimes guide the use of motility agents, which are very helpful in this disease. And in terms of pulmonology, it's important to mitigate the challenges related to aspiration, and as we know, with reflux, that can potentially contribute to worsening lung symptoms.
Thank you, Zsuzsanna. And one question for Yannick. What is funduplication? Because we start hearing this word coming out, and which are the risks and benefits of funduplication in our community?
So good morning. I'm also very happy to be here. It's really very welcome that we have in parallel the medical congress and the patient congress. It's very stimulating for us, and we have to listen to you and to try to improve and to guide also our research and our projects. So funduplication is a strategy, a surgical strategy, which is offered because one of the aspects of the GI involvement is when the esophageal sphincter is not working well, it is not stopping the gastric liquids or the gastric element to come up in the esophagus. There is the surgical strategy that can be discussed from time to time in order to try to compensate the fact that the sphincter, the natural sphincter, is not strong enough to block the reflux. This is a very simple concept and idea. The difficulty is that there is the issue regarding the sphincter by itself and the fact to block and to limit the reflux. But the point is that what is important is the upper part of the esophagus. Because in systemic sclerosis, there is not only the sphincter that may have some issues, but also the peristaltism, which is not moving enough and not moving the food enough to the stomach. So if the strategy to reconstruct a sphincter could be something very intuitive, the limitation in systemic sclerosis is that because the upper part is not working very well, it may be not good to intervene in this area in order to improve the situation. Nevertheless, it can be discussed from time to time. So it's a surgical reconstruction. So it could be complete or it can be partial. There are different technical surgery, but it needs really a careful assessment to be sure that this surgery will not be harmful in reality because of the point I was raising, the lack of peristaltism of the esophagus. So it's really a difficult decision to take. You need careful assessment, clinical, imaging, endoscopy, manometry, before making a decision. In addition to that, there is the discussion of doing surgery in systemic sclerosis, because you need the anesthesia, you need, of course, the healing of the tissue, and we know that sometimes because of the vascular problem, because of the collagen issue, the healing can be challenging in systemic sclerosis. So it's not an easy discussion to take, because you have the duration of the surgery and then the rehabilitation after that. So again, and I think this is exactly what Zsuzsanna said previously, it's a multidisciplinary discussion. You need the surgeon opinion, you need the gastroenterologist opinion, you need the rheumatologist opinion regarding the global disease, how much it is controlled, how much it is active, and how we can anticipate the healing issues. So it's something that is discussed from time to time for the very severe patient. I think the more common situation when it is discussed is when there is lung transplantation, which is discussed, because of course they can have some consequences of the reflux in the context of surgery of the lungs, but it's a very specific situation. In other case, in our practice, it's quite rare that we refer only for reflux a patient for funduplication. I don't know, Zsuzsanna, if it's also your experience.
Yes, you also have slides. So after this introduction, I would ask you to show us your slides.
Okay.
Yes, thank you, Yannick. Mm-hmm. And what Professor Allanore just said is what we have to keep in mind. Always refer to your doctor, not to Dr. Google, because Dr. Google gives you general information that can be applied also to healthy people. We are a vulnerable community, and many things, as he said, must be taken into consideration. So always your doctor.
So Ilaria, thank you. So my slides is a general introduction about the GI complication that we can see in systemic sclerosis, the prevalence of these issues, how we investigate, how we try to measure the damages, and quickly how we also try to evaluate with some questionnaires the clinical situation. It's really an introduction, and then we will be happy to have questions. So I have no disclosure regarding to this. So yeah, so the first part will be which are the medical data we have regarding the GI, which investigations we usually require to measure that, and how we can estimate your feeling about this. I would start with this slide because it was a collaborative work with FESCA that we did some years ago, and it was an internet survey, and we asked the patients that were participating, almost 2,000 patients, what is impairing your daily life? What is really disturbing your daily activities with regard to your disease? And the patient had to rank from 0 to 10 the different domains. And you would not be surprised that the top one that was identified was Raynaud's phenomenon. And of course, it makes sense because Raynaud's can be seen almost every day in all the patients with systemic sclerosis. But you can see in red that the top two was the GI manifestation. And it was a signal that really GI is really a concern in the daily life and daily activities of the patient with systemic sclerosis. We try to stratify the disease, as you know, in limited cutaneous and diffuse cutaneous. You know that these are the two main subsets of the disease. But if we look at the GI, we can see that the both limited cutaneous and diffuse cutaneous patients responded exactly the same. GI is the top two disabling complication of the disease. Another way to measure this, you know, for us it's very important to have some percentages of involvement in order to guide the research and the project. I had a look at the USTAR database. You probably know USTAR. It's a large, collaborative, initially European, now more worldwide database. And every year we send the patient data to the database for a follow-up of the patient. Today, we have 27,000 patients recorded in the database. It's really a very big one, and it's very helpful for this kind of project, the epidemiological projects. Regarding GI, we are asking simple questions, and if we try to summarize the answers, you can see that 60% of the patients are claiming to have some esophageal symptoms, 20% sub-abnormalities in the stomach, and 22% in the intestine. So again, it is showing how much it is prevalent and how much it must be addressed at each visit of the patient. Do you have some GI manifestation, and how we could try to improve them? So this is a picture of the whole GI system. And in systemic sclerosis, we have to face that all the different parts can be affected. From the upper one, we already discussed about reflux, dysphagia, the stomach emptying, and potential vomiting, nausea. And then if you go down with the lower part of the GI, obstruction may occur, constipation, diarrhea, bacterial proliferation, and malnutrition can be a causing concern of that. And at the last part, you can have fecal incontinence, which is not so uncommon in systemic sclerosis. So a few slides regarding some of the complications. So this is what I was telling you previously regarding the reflux. You see on the left the normal sphincter, which is blocking the reflux of the stomach content. On the right part, when the sphincter is not strong enough, this is promoting the reflux of the gastric acid liquid, or sometimes even the food. And this is what we should try to improve with some drugs in the context of systemic sclerosis. When it is more severe, you can see on this CT scan on the right part, it's the dilation of the stomach, because not only the sphincter is not working well, but even the stomach by itself has some difficulty for emptying it, and then there is a dilation of the stomach, which is promoting some clinical manifestations. Why this is a problem? Here you have the results of a manometry. The manometry is a very simple test. We ask the patient to drink some water, and there is previously there is a sound which is a position, and then there is a registration of the waves that are induced after drinking some water. You can see on the left a normal situation, and on the right, unfortunately, they are missing some waves to promote the moving of the liquid, the water that has been drunk, or of the food after a meal. So there is some issues regarding the nervous system to promote the moving of the water and of the food after eating, and it's commonly said that it's appearing quite early during the disease course. When we worry about this situation, one investigation that we can perform is to do endoscopy. Endoscopy, you know, it's using a camera in order to evaluate the wall of the esophagus and of the stomach in order to see what is happening. We are doing this when we suspect that there is something more than only the reflux. What can appear? You can see some bleeding because of ulcers. It can be one complication. You can see on the lower part some mucosal changes that may appear sometimes in systemic sclerosis. And on the right, you can see what is called watermelon stomach. It's a kind of telangiectasia. You know the skin telangiectasia, and the telangiectasia can also be present in the stomach, and then this is promoting sometimes some bleeding, and then you can do a local treatment. So we do not perform systematically endoscopy. We perform endoscopy when there is more than the symptoms, anemia, weight loss, unusual pain, or this kind of situation, but this is the investigation we perform in that case. In the past, we were probably doing more endoscopy, but we realized that it should not be systematic, at least in our practice. I told you that after the esophagus, there is the stomach, and here you have a picture of a barium swallow, when you can see a dilation of the stomach, and the meal containing the barium is staying too long in the stomach because of some issue regarding the emptying of the stomach. So you can see it on the left on the picture, and on the right using another way to measure it when you put some isotope in the meal of the patient. And this is telling us that the stomach has some issue for emptying, and it can guide some treatment. The symptoms that can be present in that case are nausea, vomiting, belly bloating, pain, and feeling full after the start of the meal. If we continue to the lower part, you have the intestinal involvement, and as I told you previously, there are some limitations and issues regarding the peristaltism of the whole GI system. So when it is affecting the intestinal part, you can have this kind of situation with bloating, constipation, that is showing the issue regarding the movement of the intestine. And when it is too frequent, in addition of some changes in the mucosa of the intestine, you can see what can appear what is on the right part, which is called bacterial overgrowth. Why it can happen? You remember the food is staying too much in the intestine, and on top of that, the mucosa has some fibrosis, which is impairing the communication between the lumen and the tissue. You know, we have a lot of bacteria in our intestine, and so if there are some remodeling of the tissue in the intestine, then there can be a bacterial overgrowth, too many bacteria, which are now taking the food for themselves, and so the nutrients are not anymore available for your body, and this can lead to malnutrition. This is a severe situation where specific treatment will be required. We can do endoscopy, we can do colonoscopy. This is a picture of a normal situation, and on the right part, some issue that you can see, like some also telangiectasia that can be present in the colon. But colonoscopy, you do it only if you have a suspicion of a severe complication. Again, it's not systematic in that context. If we continue and we go down, another clinical situation that we have to talk about is fecal incontinence. And Ilaria was talking about taboo. It's probably one of them. And unfortunately, it is not very well known. I just indicated here a study that tried to analyze all the study about fecal incontinence. You can see that the prevalence is ranging from 0.4% to 77%. So it means that we don't know how often it can appear, and it's really a limitation for our work, because sometimes the doctor does not know how to ask this to the patient, and also the patient is not very comfortable to tell the doctors that he has some issues regarding the fecal continence. So in the transparency of the discussion, with the objective of a global and holistic assessment of the disease, it's very important to communicate about this in order to evaluate whether there is a physical limitation there, or is it common, not common, which etiology we can identify, it is purely systemic sclerosis, is there something else, and then to try to improve the clinical situation. Here I put also a picture of a manometry. It's the same thing as the upper part. There are some issues regarding the sphincter, the anal sphincters, and also the motility of the last part of the GI. But this is something probably we will talk again at the time of the question. We know that it can appear in systemic sclerosis. Probably it's not very uncommon, but we don't know exactly the prevalence, and it's important that you share with your doctor the symptoms you can have regarding the fecal continence. To end, so these were the investigation we can do. You know that in medicine, we can well address a clinical situation when we are able to measure it. If we want to improve a situation, it's good to understand that it is present, but to be able to measure, to quantify the situation. Because then, when we do an action, we are able to see whether the action we had was helpful or not helpful. And unfortunately for the GI, we do not have so many tools regarding patient-reported outcomes. The single one that is used is called the UCLA questionnaire, which is covering the different aspects of the GI, as you can see, reflux, bloating, diarrhea, constipation, and so on. And you have some questions where you rank your clinical situation. It's probably not a perfect tool, but it does exist. It has been validated. It is used in the clinical trials, and it's important that you answer this kind of question, again, for your doctor to know your situation, to measure your situation, and to see when he is doing an action, whether it is beneficial or not. And with that, this is the end of my presentation. So we are absolutely convinced that GI impairment is a very common situation and leading to common clinical manifestation. We know that it has a heavy burden. You started to comment about how to go to restaurant when you have some GI problems. There are clearly consequences on the quality of life. It's important that you explain in details the symptoms that you feel in order to be able to locate where is the problem, how much it is severe, how often it does happen, and what are the details of the symptoms, because we need to map exactly the damages, to decide whether investigations are required, yes or no, in order to tailor the management. And with that, I've finished, and I will be happy to take some questions later on. Thank you very much for your attention.
Thank you. Are there any questions for Professor Allanore? No. So I would like to ask you if, after a broad discussion with your patient, would you still recommend a surgery for fecal incontinence?
So never as a first intervention, for sure. So first, you have to be sure that it's only related to systemic sclerosis, because some other medical problem can appear. Then you have to try to see how much the constipation and so on have a role on this, diarrhea, constipation. Then you have to do some investigation to measure the local lesions. Usually the first step is rehabilitation. And sometimes rehabilitation, like the one that is proposed after the obstetrical and after the delivery of a baby, it's a similar rehabilitation that can be proposed. And it's not perfect, but in some cases it can really improve the situation, improve also the understanding of the functioning of the fecal continence, and with some time, with different strategies, it can improve, and at the very last time to discuss the surgery. But you know, there have been also some discussion regarding whether we can do some stimulation, local stimulation, but it's very specific. And again, we go back to the specialized discussion between the gastroenterologist, the surgeon, and the rheumatologist. And personally, I think that we have almost never referred any patient for fecal incontinence to surgery specifically related to systemic sclerosis. Sometimes you have some other problems for which surgery can be helpful on top of scleroderma, but not purely for scleroderma.
Thank you very much. Very good explanation. That because we bring here extreme cases, but the normal situation is usually different and milder, thanks God. So, Zsuzsanna, would you like to do your presentation for us?
Sure.
And do not hesitate to submit questions.
Good morning, everyone. I'm Zsuzsanna McMahan from Houston, and I'm really delighted to be here this morning. Thank you for inviting me. The GI tract is really, again, something I'm really passionate about trying to understand because it impacts your life in such great ways, and I know it's such a struggle. So I hope in the next 10 minutes, we can go through a couple of cases where you can learn about how we approach the management of a couple of complicated cases in scleroderma. These are my disclosures. So as you know, scleroderma-related GI disease has major impacts on quality of life. And these are some of the quotes that I hear from my patients every clinic visit. And if you imagine how much of our life as a human evolves around social meetings for coffee or for food or for a drink, it's really challenging to deal with complications that don't allow you to go far from a bathroom or be with friends and feel comfortable without getting sick. And so these are the types of things that motivate us to try to make a difference for you. And so Ilaria asked me to go through a couple of cases, one about challenging acid, really refractory acid reflux, and one about fecal incontinence. So this is the first one. So this is a case of a patient. Her name is Maria. She's 52 years old, and she has early symptoms of scleroderma. She has daily heartburn, feelings of regurgitation, and nighttime coughing, which are really challenging for her to manage. Her symptoms persist despite daily use of a proton pump inhibitor or acid blocker. And so she sees me in clinic, and we increase the dose of the acid blocker. And ultimately, her symptoms are still problematic, so we increase the dose to twice a day. And so, of course, even before increasing the medications, you want to make sure that while you're going through these medical adjustments in your treatment, that you're also managing the basic things that can impact the gastrointestinal symptoms. So there are several things that we offer to our patients that are small things but can make a big difference in combination with medical therapies. So one of those things is eating meals that are small, but eating them more frequently in order to maintain your weight. Raising the head of the bed, as you can see in the picture, here, so that gravity helps to keep food in the stomach. As Dr. Allanore mentioned, the lower esophageal sphincter can be weak, which is problematic and can aggravate reflux. Taking medications exactly as prescribed. So the proton pump inhibitors or acid blockers, those medications, especially the newer classes, need to be taken 30 minutes before you eat. Because when you swallow them, many of them are inactive and they require the acid from the stomach to turn them on and to work. So just taking them at the right time can make a big difference. Staying upright after eating, for the same reasons it's helpful to sleep on a wedge pillow. That can be very helpful. And avoiding late night intake of food and drink also helps avoid waking up in the middle of the night with terrible symptoms. And then minimizing the intake of processed food can also help, because just bloating in your stomach increases pressure and can put pressure up so that the acid goes into your esophagus. And so all of this is important to consider. So when acid reflux is still not well controlled, we have the opportunity to change medicines or use medicines in combination. So you can see here that the PPI was where this patient started, and there's an opportunity to switch to something called a potassium competitive acid blocker. These are newer medications. They were approved in Japan about 10 years ago, but just recently were approved in the United States, and I think approval across Europe is variable. But these medications can be helpful as they're a bit more powerful to control acid reflux. And then increasingly, data in scleroderma is showing that patients with the most severe symptoms of acid reflux actually have problems with movement of their intestines below the esophagus, so in the stomach, small bowel, or colon. So really optimizing the management of those patients can be extremely beneficial for patient symptoms. So we often use those, the acid blockade in combination with a promotility agent. And why do we want to use a promotility agent? This is a pretty cool picture created by AI, and it's essentially showing that the intestine, which you can see here is muscle layer, this is the inside where the food passes, and these are the nerves that control the gut movement. Over time in scleroderma, the muscle, this nice layer here, can get weak and thin with patchy areas of fibrosis affecting its ability to move. And so by trying to improve the communication between the nerves and the muscle, we can get the gut to move a bit better. And so there are many different medications that you can see here that improve that movement and function in the gut, and that can be used clinically to augment acid blocking therapies. And so what did we do for Maria? Ultimately, we combined the acid blocking agent with a promotility agent. That was her preference. It's important to negotiate with your doctor on your values and how you like to take your medications and what you think is most reasonable, because we want you to feel comfortable taking them, and compliance is the best way to fix the symptoms. And then also in patients with really significant reflux, such as in this case, it's important to speak with a gastroenterologist to rule out other things that could be contributing. Sometimes there can be scarring in the esophagus, sometimes there can be infection, sometimes there can be bleeding, and those need to be addressed before we only address the acid reflux. And then finally, there are various nutritional options that can be used to really help support improvement in your symptoms, and we work with a nutritionist in that realm. And so now we're going to move on to the second case. This is a patient named Julia. She struggles with bowel control, and she's 60 years old and has a long-standing history of scleroderma. She's anti-centromere positive, and this is something that we see often in this group of patients. And she presents to my clinic with loose stools and unexpected bowel leakage. But she was initially scared to talk about it because she was worried that it was her fault, that she'd done something wrong, and she was embarrassed. And so it's really important to keep an open dialogue with your doctor and have a doctor that you're comfortable talking to, because it is important for us to know so that we can find the best way to help. And remember, it's not your fault. It's nothing to be embarrassed about. This is a complication of the disease, and it's really common. So some of the things that you can ask your doctor when you see them to try to help improve your care include, could diarrhea or bacterial overgrowth be contributing? Would pelvic floor physical therapy help me? And what treatments are available if these interventions don't work? And there is a growing body of evidence, slowly but surely, that's beginning to answer some of these questions. So again, the first step is when you have symptoms of fecal incontinence is to talk to your doctor. Again, no need to feel embarrassed. If there's diarrhea present, that can often be a consequence of something called small intestinal bacterial overgrowth. And then, of course, normal things that cause diarrhea and the rest of the population can contribute. So there should be an evaluation. Sometimes patients get malabsorption where they can't absorb their nutrients, and so diarrhea can be present in that situation too. But once the diarrhea has been evaluated and treated, if the symptoms of the incontinence still persist, that's when it would make sense to get some additional objective testing, such as an anorectal manometry study, which measures how well your muscles control your ability or your inability to have a bowel movement, and neurosacral stimulation and pelvic floor physical therapy are two options that patients sometimes find helpful depending on the results of that test. So the team might suggest, your medical team may suggest dietary modification as well. There's not a lot of data in this area yet, so we extrapolate a bit from other diseases, but what I can tell you is that modifying fiber intake can sometimes be helpful and sometimes not. So it essentially helps with bulking of stool, so you have to be careful if you have slow transit in the colon, because then it will just sit there and not move and get bulkier. But in some patients that aren't getting enough fiber, that can contribute to loose stools, which can aggravate incontinence. So it's important to minimize, to see how well you tolerate fiber, and if it helps you, then use it. If it doesn't, then stop. Minimizing caffeine intake, which can aggravate fecal incontinence, can be helpful. Minimizing artificial sweeteners, which also can aggravate incontinence, is helpful. And then there's some data that shows that lactose and fructose are poorly tolerated in many patients with scleroderma, and so eliminating or minimizing those in your diet can also help. So other considerations, again, depending on the situation, can be the pelvic physical therapy, where you work with a physical therapist to help strengthen your pelvic floor and control muscle movements there to minimize the incontinence, and my patients have had some really good benefits from that if they stick to it. And then nerve stimulation, you can see in these pictures here, oftentimes there are a bunch of nerves at the lower back, and when they're stimulated, they can help the control of the anorectal muscles, and in patients that don't have a lot of sensitivity in that area. The data in scleroderma is still evolving, but it can be helpful sometimes if there are no other options. And then finally, again, we addressed Julia's care plan with some dietary modification. She was treated with rifaximin to help her small intestinal bacterial overgrowth, and that controlled her diarrhea, which slightly improved her incontinence. Anorectal manometry showed the inability of the muscles to collaborate, and so she went to pelvic physical therapy, and they worked with her on helping to strengthen the pelvic floor, and then she had ongoing support from gastroenterology and her rheumatology teams. She did better in the longer term. So I just want you to remember that your struggles are real. They are part of scleroderma. They should not bring you shame, although I know that many times it can feel that way. But we're here to help you, and if there's ever anything that we can do to try to provide guidance or resources, please feel free to reach out, because we really care and want you to feel better. So,
Thank you, Zsuzsanna. Thank you very much. Is there any question? No, but some of you, yes, yes, please.
I asked both speakers, if it's possible, what do you think about the impact of immune suppression on GI system? Is there any benefit? What is your personal experience?
It was your question, the one I wanted to raise. Thank you.
okay. So, I'll answer first, and then we'll hear what Dr. Allanore has to say. So, immunosuppression, that's an interesting question. So, recent data from our group has shown that there are some patients that have more rapidly progressive disease, and then GI involvement, and then patients that have GI involvement that happens much later. And in addition to that, there's some there's some recent literature, not so recent anymore, but that demonstrated that there are antibodies that are functional, meaning that they cause problems in the gut, and that those antibodies are present typically in the patients that progress really rapidly. And so I think, and more data is needed, but some case series have shown that IVIG can help the patients with more rapidly progressive GI involvement. They're smaller studies, they're case series, but I think based on the evidence that we have and the small data from those studies, that would be the group that is most obviously going to benefit from immunosuppression. But it's less clear whether the patients with longer-term GI disease would benefit from immunosuppression. That's the group that has the Raynaud's and the pulmonary hypertension, and we're not really sure about when and how long to treat with immunosuppression in those patients. So I think there's a role, but it's still being defined. But I think ultimately it will be a component of management of GI.
Thank you.
And
Thank
Dr.
you very
Allanore?
Your question is really timely because we are doing more and more immunological intervention in the patient with systemic sclerosis. I think there are two different sides to analyze. The first one was because we have been talking about bacterial overgrowth, presence of microbes in the intestine. Sometimes we were afraid that the treatment we are offering could be harmful and could promote the GI manifestation related to the bacteria that are there. And so far, the answer is no. There is no harmful effect on the GI, despite the intense immunosuppression that sometimes we are offering to the patient. So this is the good news. The bad news is that so far, whatever we are using, at least in the clinical trials in which we measure carefully with the questionnaire the GI, we have not seen any benefit or trend in benefit using our immunosuppressive strategy. So probably the inflammatory part is not so critical to modulate the symptoms of the involvement. Probably less than the nervous system, maybe at the very beginning, the vascular system. But unless some very specific situation like Professor McMahan raised with some very specific cases in which immunoglobulins can have been discussed in some patients, for the rest, it's almost neutral regarding the data we have so far. It would be my opinion today.
Yeah.
Thank you. Other questions?
Oh, there's one.
Yes. Just could you repeat the question with the microphone?
Is celiac disease often seen concurrently with scleroderma?
So I would say we don't see it very often, but it can overlap. Many of the autoimmune rheumatic diseases that we see do come in bundles, and so while I wouldn't say it's really highly common in systemic sclerosis, you can see it.
It's a good point, because in systemic sclerosis we are more and more seeing polyautoimmunity. We are seeing in many patients thyroiditis, Sjögren's syndrome, and some of it. But I think we have not seen autoimmune digestive diseases associated with systemic sclerosis. So I don't know why, but in the practice it's very uncommon to identify celiac disease.
Yeah. And I do screen for it. In particular, people with bloating and diarrhea or rashes and some joint pain, I will look, but I haven't really found it often.
Thank you, Prof. McMahan.
Hello. I can speak in Spanish. My English is very bad.
Okay. Sure.
¿Hay alguna investigación o estudio que se haya hecho sobre el síndrome de Raynaud en el estómago?
So I think the question is there a syndrome of Raynaud's that affects the stomach? So that's an interesting question, whether Raynaud's can affect the gastrointestinal tract. There are some reports of Raynaud's affecting the tongue, and the reality of that is not entirely clear, and the impact of that is not wide-reaching. But it's a question that is hard to answer because we really can't visualize that tissue. So I would, my initial response would be no, but it's interesting because I have anecdotally heard from patients that putting a heating pad on their stomach or whatnot can improve symptoms. So, but it's not well studied, it's not well known, and I think there's more to be determined in that area.
Thank you very much. No other questions, because now we need to listen to Catarina Leite.
Thank you, Ilaria. So I will talk a little about this question from the patient perspective. I think the GI complications sometimes can be seen by the elephant in the room for some people with scleroderma, sorry. So we know that scleroderma can have serious GI complications. So what can we do? We can understand the symptoms, try to learn and recognize all the symptoms to tell the doctors. And that is moving from the silence to a proactive management. So we start with the reflux and the social barrier that becomes from these symptoms. So I heard GERD can affect nearly 90% of scleroderma patients, and it's not only discomfort. It affects what you eat, where you go, and how you sleep. This is very important for the quality of life of the persons. And so eating can become a logical challenge. The fear of having reflux or needing a special diet can lead to isolation. We can think twice if we go to a dinner with friends, and what do we eat? Maybe the food can make my GI symptoms worse. Also, the problem that almost of we have in moving the mouth, sometimes it's difficult to eat with the mouth completely closed, and that is it's a social problem too when we eat in public, and this causes social anxiety, of course. I bring a sentence for a patient advocate from Canada, an important patient advocate that unfortunately died this year. And she said that the most debilitating symptoms are often the ones others cannot see, like the FESCA campaign, See the Unseen. Speaking about them is the first step toward control. So if you have problems with fecal incontinence, with reflux, anything, you don't have to have shame to talk about it. It's important to tell the doctors so they can help us. And we keep understanding these symptoms. The difficulty of swallowing is dysphagia. What impact in our daily life? Slower meals, risk of choking, coughing, and that could be a really problem during a meet. The bloating, clinical term dysmotility, can cause abdominal pain, clothing discomfort, and fatigue. Fatigue is one of our symptoms with more impact in the daily life. So we have to give these symptoms the real importance because it is one of the most difficult to manage in scleroderma. And also, what can we not predict? The urgency to go to the bathroom and the need to immediate bathroom access. And so, the fecal incontinence. As the doctors already talk, the anal sphincter muscles and nerves can be affected by fibrosis. And this is not our fault. This is not a question of willpower. This is physical complication of the disease. And so we should talk about it because it's not our fault. It's not something we can choose. Understanding why this is happening help reduce the shame and helps to focus on the practical solutions. That's what we want. And that is a real problem when people suffers that fecal incontinence. The first thing you want to see in a new place is, okay, this is very beautiful, where is the bathroom? And in the places you have to know any bathroom in the where are they located. Some countries have a can't wait card who gives you priority to use the bathroom when there are a lot of persons in front of you to use them. I don't know if in your countries that exists. In Portugal, we have talked about it so many years ago, but it don't happen. And then you have to plan if you are in the travel. You know when you have to stop from the next toilet. It's logistical problems that the other people cannot understand, but for persons with fecal incontinence is really, really important. So, as you already say, but the strategies that we can use is small meals, frequent meals that minimize the reflux, knowing that the gravity can help us in the bed, walking after a meal simulates natural intestine movement and can be also a good strategy for us. And we can also do the pelvic floor physiotherapy, as the doctors already talk about it, because physiotherapy is not only to the back or knees, and specialized pelvic floor training can help to retrain the muscles involved in the bowel control. Work with a specialist can reduce accidents because they are really accidents and significantly improve the quality of life and the confidence levels. I think, at least for my experience, this particular symptom is a little worse, social worse, not physical worse, in the younger patients. The shame, I think, is more felt. But this is only my opinion. When I was 20 years, I have this problem, and I will not stand here talking about it for sure. And it's really a taboo. Even with my friends, it's not easy to tell something. I have an accident, and I don't have 1 year, I have 20, so it's difficult to say something like that. And so, be a team with the doctor is the most important, but for that we have to really talk with the doctor about these questions. Keep a symptom diary. This can help, because sometimes we arrive to the doctor and we say, how frequently do you have these problems? Many times, 2 weeks ago, I will. No, if you have a symptom diary, it's more practical and useful to remember everything you want to tell your doctor. It's better communication, and the communication with the doctor can be a real key for success. Be direct. We have to call the things by their names, not I have a problem, you know, to go to the bathroom. No, we have to tell the doctors, be direct, using, for instance, fecal incontinence. It is fecal incontinence. It's not another name. Is that and tell the doctor in the way they can understand the severity. And then ask for specialists. If you talk to the rheumatologist or to the internist about this problem, ask them to refer to a gastroenterologist or a nutritionist to help what you can or cannot eat. That is very important too. As we already know, some food can be really aggressive to our GI system, and we have to know what we can or cannot eat. That is a real problem, but we have to be correct with this. I like very much to eat, and I'm so sorry I cannot eat everything, but okay. And mental health support. It's important to discuss the emotional impact of these symptoms and all the symptoms in scleroderma, I think. The anxiety can worsen GI symptoms, so we have to need to control anxiety and stress, to manage stress. These are strategies that we can use, and you can ask for a psychologist because it's really, really important. And this is the final message, that we are not scleroderma, we have scleroderma, and I think this is a thing we keep in mind. We have to keep in mind, we are not the disease. We just have a disease. And understanding our body we can adapt strategies, personal strategies. I think this is a little individual too. And that way we can minimize the impact of GI symptoms and live a full and connected life. And thank you very much.
Thank you, Catarina, for your great message, passionate message. Thanks to our clinicians for their technical and scientific message. And we are out of time, but I must say that this, in 2028, there will be part 2, because it's such a wide topic of great interest considering the questions we have received. So I have here other questions I can't make because of time, but thank you very much, and also to you for your attention.
Thank you.
Thank you.
Thank you for having us.
Thank you.